Good afternoon. Today I am discussing on the topic of fluid and electrolyte balance management in COVID-19. So we all are bearing the brunt of this pandemic world over, and I think we know about COVID. Everyone in the society also knows COVID more than anyone else. So, coming to my topic, the fluid and electrolyte balance in management of COVID-19. So, here I want to highlight that the fluid and electrolyte balance are management is backbone of the treatment in any kind of infection. So, whether it is COVID or it is any other infection, it is the backbone. So, before we come to the management, let's discuss few points about the physiology of the body fluids and electrolytes. So water is the most abundant constituent in the body, comprising approximately 50% of body weight in women and 60% in men, and it is distributed in two major compartments: extracellular fluid and intracellular fluid. Around 55 to 70% is intracellular and 25 to 45% is extracellular fluid. And then this extracellular is divided into two major compartments: intravascular, which is blood basically, and then interstitial fluid, which is the fluid around the cells. So this is a beautiful pie diagram showing what I have dictated in the previous slide. So intracellular fluid is 65%, plasma is 8%, interstitial fluid 25%, and transcellular fluid is 2%. Then this diagram is basically also showing the same thing which I have already elaborated. So and this is a very beautiful pictorial presentation. Just have a look, just a glimpse, just a glance on this slide shows that newborn, the body weight, the contribution of water for the body weight is 80%. So fluid and electrolyte management is very critical for management of children. So adults, it's around 60%, in female it's around 50%. Now let's discuss some points regarding the physiology of the electrolytes. So we all know that electrolytes are distributed both intracellularly as well as extracellularly. So the predominant intracellular electrolytes are potassium, magnesium and phosphorus, and predominant extracellular electrolytes are sodium chloride and bicarbonate. So these, what is the importance of these electrolytes now? Sodium, most important electrolyte in the extracellular compartment, and next is potassium. It is the most abundant electrolyte in the intracellular compartment, and it is essential for normal membrane excitability for nerve impulse. Then comes the chloride. It regulates osmotic pressure and assists in regulating acid-base balance. Next is calcium. It promotes nerve impulse and muscle contraction and relaxation. And magnesium, it plays important role in carbohydrate and protein metabolism, storage and use of intracellular energy and neural transmission, and it is important for the functioning of heart, nerves and muscles. Now this is a bar diagram very beautifully showing the distribution of these electrolytes in comparison to extracellular and intracellular compartments. So we can see that sodium, the ratio of extracellular to intracellular is 14:1. So it is outside the cell, it is 14 times more compared to what is there inside the cell. Now this potassium, if we see extracellular intracellular ratio, it is 1:28. That means the potassium is 28 times more inside the cell compared to the extracellular compartment, and this gradient is maintained by ATPase. It's a energy dependent process. So ATP pump, the sodium potassium pump, which is maintained by ATP, is basically responsible for keeping sodium potassium level very high in the cells and sodium levels very high outside the cells. Then comes the calcium. Extracellular to intracellular compartment ratio is 5:1, so it is more outside the cells because it is required for contraction. Magnesium, again the extracellular to intracellular ratio is 1:19. Chloride, extracellular to intracellular ratio is 26:1. Bicarbonate is 3:1, and phosphate is 1:19. So phosphate is also predominantly intracellular. Now, before we jump on to the management, let's revise what is basically the normal levels. So we all know the sodium, normal level of sodium is from 130 to 145. So anything less than 130 is hyponatremia. Anything more than 145 is hypernatremia. Potassium, the normal level is 3.5 to 5. So anything less than 3.5 is hypokalemia. Anything more than 5.1 is hyperkalemia. Chloride, the normal range is from 98 to 107. So anything more than 98 is hypochloremia. And magnesium, the normal range is from 1.5 to 2.5. So anything less than 1.5 milliequivalent per liter is hypomagnesemia. Now, this is basically the renin, angiotensin, aldosterone loop system. Now, why we are discussing this? Because whatever electrolyte imbalance it happens in COVID or in any other disease, this is the basic physiology behind that electrolyte imbalance. So we all know that renin is secreted from the kidney in response to low blood volume. So whenever there is hypovolemia, the renin is secreted from the kidney. So it acts on angiotensinogen, which is synthesized in the liver, and this angiotensinogen is converted into angiotensin 1. Now this angiotensin 1 is converted into angiotensin 2 by the ACE enzyme, that is angiotensin converting enzyme in the capillaries in the lungs. And this angiotensin 2, it acts on adrenal to secrete aldosterone, and it also acts on blood vessels to cause vasoconstriction. Now this aldosterone, we all know it goes in the kidney and helps in the absorption of fluid and concurrently sodium also. Okay, so basically this is a process to increase the blood volume and to increase the pressure whenever there is fall in blood pressure. So this is I have already told. Now this coming to the main core topic, COVID coronavirus. So we all know that this COVID-19 is the cause of acute respiratory illness, which has spread around the world. The virus infects the host by binding to ACE2 receptors, which are predominantly present in the organs which have very high capillary network, like lungs, and which is the main entry point for the virus. But they are present in gut, they are present in kidney, they are present in the brain, they are present in testicles. So it is present in ubiquitous, but mainly the tissue where the capillary network is more. So predominantly they are present in the lung, gut and kidney. Now due to the presence of ACE receptors in the kidney and gastrointestinal tract, definitely these organs will also suffer whenever patient will have COVID-19 infection. The virus can be seen in patient and can cause acute condition like acute kidney injury and digestive problem for the patients. The cytopathic effect of COVID-19 on podocytes and proximal tubule cause AKI in patients who suffer from COVID-19, and podocytes are mostly there because they are very sensitive cells to both viral and bacterial infection. So when they suffer, patients suffer from AKI. So therefore, more consideration should be paid to new surveillance and renal function and urinary management of COVID-19 patients. Kidney disorder in COVID-19 occur as a result of complex factors, so it is important to note that AKI is correlated with considerable mortality in patients who are suffering from COVID-19. GI tract, I have told that these receptors are present in GI tract also. So the involvement of GI tract, it can be from 11.4 to 50% in COVID patients. So it can damage the GI tract and cause GI symptom. In patient with COVID-19, it can damage normal intestinal mucosa and it can disrupt its normal function, leading to GI symptoms and difficulty in absorbing the nutrients. So SARS-CoV-2 can also impair normal intestinal flora and can lead to GI symptoms, especially diarrhea. Now, this is a grading system. Now, why I am mentioning grading system here? Because for grade mild to moderate, we need not to monitor electrolytes. So patients who are fit in the severity index mild and moderate, we need not to monitor electrolytes. and we need to monitor the fluid and electrolyte, especially when patient is in the severe and critical category. So in severe category, patient who has dyspnea, respiratory frequency more than 30, saturation is less than 93%, partial pressure of oxygen to FiO2 ratio less than 300, and lung infiltrates in more than 50% area, that too developing very fast within 24 to 48 hours, they fall in severe category. And any patient who has respiratory distress, septic shock, and a multi-organ function falls into the critical category. Now, the lot of research has happened in COVID regarding the electrolyte imbalances in COVID patients, and what they have inferred from what we have, the data has been analyzed, and what they have found that sodium was significantly lower in patients with COVID-19. So hyponatremia is a very common finding seen in around 40% patients, 40 to 50%. Next electrolyte problem is hypokalemia, which is seen in around 30% patients. Calcium is also significantly low, so hypocalcemia is the third problem encountered in COVID patients. Not much difference in chloride level has been seen in COVID patients. So hyponatremia, hypokalemia, and hypocalcemia are the three electrolyte disturbances which are most predominantly found in patients with COVID-19. The most common electrolyte disorder is hyponatremia, which occur with heightened risk of mortality in hospitalized patients. And moreover, we all are using chloroquine and hydroxychloroquine in first wave of COVID. We have given these drugs, though they also can cause some amount of hyponatremia. And people with COVID-19, they may be on RAS inhibitors drugs, so that exacerbate the hyponatremia. Hypokalemia is, we all know, is known to exacerbate ARDS and acute cardiac injury, which are common complications in COVID-19, especially in patients with underlying heart or lung disease. Hypokalemia also provides the pathophysiological clue that SARS-CoV bind to its host receptor ACE and likely reduce ACE2 expression, thus leading to increased angiotensin II, which can cause increased potassium excretion by the kidney, leading to hypokalemia. A second potential contributor to hypokalemia is the gastrointestinal loss. So diarrhea and nausea, I have already told, are very common, seen in around 34 to 3.9% of the cases. And it is advisable to assess the electrolyte status upon patient's presentation and to serial monitor electrolyte disturbances throughout the course of illness in order to establish timely and appropriate corrective actions. Now this is a flow chart which can very easily guide us how to take care of patients who land up in ICU. So we have to assess the patient as a whole, but we have to be very careful because we all know it's very infectious. So after wearing the proper kits, proper mask, proper precautions, we have to assess the patient. Look for any arterial hypotension if mean arterial pressure is less than 65, any evidence of tissue hypoperfusion. So when we encounter any of these clinical signs like shock, we have to immediately see the patient and see whether we can find the cause for that. So immediately we should obtain the blood cultures, we should begin appropriate broad spectrum antibiotics, consider diagnostic imaging, and institute prompt infectious source control protocols. And we should always give IV bolus fluid because these patients have hypovolemia. So we should give IV fluid bolus, which can be continued for 15 to 30 minutes, and then we can assess after half an hour whether the patient's blood pressure has come to normal or not. We can also measure lactate level, ABG, and troponin levels because these are the ABG level will guide us for the treatment, and definitely these patients are at risk of myocardial infarction, so troponin levels are important. So rapidly assess patient after half an hour again. So if patient is still in shock, we have to assess the cardiac functions. So look for LV and RV. We have to go for echo, ECG, and troponin levels. And if resources are low, as per protocol, consider arterial blood pressure monitoring, and we have to insert the central venous line for vascular access. Now, if there is arterial hypertension, we can give more fluid depending upon the clinical condition and underlying health comorbidities of the patient. And if patient blood pressure doesn't come, then we have to start vasopressor. Norepinephrine is the drug of choice. and if we found from JVPs on lower side, we can give more IV fluids. Now again we have to assess the patient within an hour. So repeat the lactate level, perform clinical examination, which is very difficult, but partial can be done, and reassess if patient is deficient in fluid or not. If shock still persists, then reassess the etiology. We are maybe missing something else. Change the antibiotic. Consider adding another vasoconstrictor like vasopressin, and if norepinephrine is not available, we can give epinephrine also. Give the steroids, and hydrocortisone is definitely best for refractory shock. We all know that in patient of COVID, the drug of choice is dexamethasone, but here we are giving only for shock. Okay, so patient has shock, give hydrocortisone, and if shock persists, then we have to take the patient on ventilator and re-escalate the therapy. So hypovolemia, we have to note that hypovolemia is very common in COVID-19 patients. Crystalloids should be the fluids of choice for resuscitation. Albumin can also be given if patient's albumin is less than 3 gram per deciliter. So overall assess the patient, and then we have to overall assessment is important regarding fluid and electrolyte management. Thanks.